Last week, a day like this, a week ago, President William Ruto was in Western Kenya, and he chaired a cabinet meeting in Kakamega, and he said, see, for the first time in the history of this country, the cabinet is meeting in these parts of the world. Okay? Now, a dispatch from the cabinet on that day said, in honor of the administration's pledge to accelerate Kenya's attainment of universal health coverage, as set out within the administration's plan for a healthier nation, espoused under the bottom-up economic transformation agenda, the cabinet considered and approved crucial bills that promote healthcare for transmission to Parliament. Those crucial bills are the Primary Healthcare Bill 2023, the Digital Health Bill 2023, the Facility Improvement Financing Bill 2023, and the Social Health Insurance Bill 2023. These bills will usher in a paradigm in the legal and institutional framework for healthcare in Kenya, repealing the current National Health Insurance Fund and establishing in its place three funds: the Primary Healthcare Fund, the Social Health Insurance Fund, and the Emergency, Chronic and Critical Illness Fund. What? On the other hand, the Digital Health Bill addresses the existing legal and regulatory gaps in framework for the e-health ecosystem and its data life cycle, enabling development of standards towards the provision of mHealth, telemedicine, and e-learning in healthcare, and so on and so forth. Now, when people say this, like, okay, so NHIF fund gone, new fund coming, new fund coming. What is happening? So who are we paying? Are we being deducted 3 times? Are we not? And then the whole conversation of 2.75% deduction comes in. Now, the president's advisor on health financing is Dr. Daniel Mwai. He joins us for the conversation this morning. Good morning, Dr. Ari.
Good morning.
Welcome to Kenya's biggest conversation.
Thank you.
That's the hot seat of the Situation Room. Make yourself comfortable.
Thank you.
To welcome you to the conversation, CT has the day's proverb. And this week's proverbs are from which country?
Gabon.
Gabon.
Officially known as the Gabonese Republic.
Mm-hmm.
Okay. When spider webs unite, they can tie up a lion.
When spider webs unite, they can tie up a lion.
Yes.
Dr. Mwai, what's your interpretation of this proverb?
Yeah, thank you very much. I thought is a proverb relating to mathematics of financing. and but yes. In the same line, probably I would think that when alone we may look a little bit weak, and may not be able to conquer the things that we have in terms of life challenges or even things that we want to do. But when we come together, I think we can become such a tremendous force that can be able to withstand even the strongest.
Now,
in my opinion,
you see the connection with health financing?
Yes, I think there's some mathematics there. So, so pleasure.
When you pull resources together,
yes,
as many webs, then you can even entrap a lion.
As they say, numbers don't lie. They don't lie.
It's a big one.
But people lie with numbers.
So people lie with numbers.
They do.
But the numbers will not lie.
The numbers will not lie.
Dr. Daniel Mwai, the president's advisor on health financing. Please, what does that mean?
Yeah, I would just highlight that, one, I'm a health economist. That is what I specialize in. And I specialize specifically in healthcare financing, economics of, what we call economic evaluation, to make sure that the money is deployed, optimally. The key question is that we have scarce resources, and because of scarcity in resources, we have to make choices, and therefore we have to really look at where do we make the best choice in terms of putting resources for the Kenyans. So in this, time, what you're trying to do as a country is to assist the president in achieving the aspirations that he have and promised to Kenyans on matters relating to universal health coverage. And the GRU, and actually the DNA that drives that service provision for the Kenyans, is actually financing. And therefore, that is why I think we are here. And that is why we have to really, digest and also discuss the healthcare financing, more elaborately, so that all Kenyans also understand, because when you go to the market, you carry resources to buy something. So what are you also buying? So these are some of the questions that I think are optimal to answer this morning.
Indeed. Dr. Even as you're getting into this, we're looking at UHC as general elements, but we also know that discussions on UHC had begun and probably reached at a certain level in the previous administration. So when we talk about the money that's going to be spent, how this program is going to be financed, is it taking into consideration the strides that were made previously? I mean, we had pilot projects in 4 counties, we had certain things happening already. When you look at the financing as we start, is it taking into consideration the things that had already been done? Or are we looking at financing a project where essentially we're starting from scratch?
Thank you. I think governments, are additive. So you continue growing. You don't start from scratch, so to speak. But it's important to note that this agenda, specifically on UHC, have been attempted twice in the past. During the Kibaki time, it was tried again. And also, of course, the past regime also tried the same. So what we are saying is that we have picked lessons. And also, we have also seen the areas that the sector actually has gone long in terms of, crafting the UHC agenda. And sometimes this is actually, driven by one being sometimes over ambitious in terms of the scope. Not sometimes telling each other the truth in terms of what can we achieve within a certain duration of time, how can it be achieved, and do we have ability to actually do it. And if you have no muscle to actually buy the services that we are promising, then it becomes difficult actually to achieve the agenda. So we are building up, learning from, it is a learning, adapt, and scale up. Okay. I mean, that is usually the main driver. You have to learn what you have already been able to do. You have to adapt, because some of these things are not, all our structures are very different. Even now that the Kibaki time and now this devolution, there was counties, there were no counties. So there are several metrics that need to be, kind of changed so that they fit. Okay. And lastly, of course, to implement.
Okay. So now based on that, the parts 2 of that question would be, so from your action plan, what now will this financing be applied to within this program?
Thank you very much. I think for us to understand where the money will go, I think it is important for us to look at our financing architecture of health, so to speak. Yeah. And why this is important is because if we focus on the past, for instance, we have largely been a curative country. We focus on, allowing disease to happen, of course, as we keep quiet. But now when they happen is when we start reacting and we start taking actions. Yeah. So this push towards Afya Bora Mashinani has several issues that need to be looked at, critically. One is that people should be able to seek services closer to their households or to where they stay. So that is very important, because when we did an analysis in the past that, was looking at the costs that accrue to the demand side of the economy, this is actually the people who come to seek care. Transport cost is a real major cost to households. And of course, the caregivers staying out, away from their household. So that is one element that we need to really take note of. But when we talk about that, then we ask ourselves, then why do people move far?
Yeah.
The people move far because of largely 3 reasons. The main one is lack of commodities in facilities. Yeah. So you go to your nearest facility, they have no commodities. Why would you go? So you bypass that facility to go far. The second thing is a lack of the right human resource. So our facilities, of course, are not well equipped with the right human resource. And therefore, that you'll not be able to get good quality of care. And because people don't love going to hospital. I mean, the hospital is not...
Our facilities are not facilitated by adequate human resource.
Correct.
Let's expand on that a little bit, please.
So what I mean is that even after the devolution happened, the financing that of course have gone to the facilities is still low. And being low, what means that inputs that can be purchased with the money are also low. And therefore, you find that there are facilities that have been built but the human resource that have been, deployed there are not adequate to actually provide quality of care, and therefore people bypass the facility. I'm explaining why people move away from a facility that is closer to go far. And the last reason is the inability to have good lab, or what we call diagnostic capacity. So people are unable to, get the right tests. So they are prescribed, they have to go far. So even if you want people to be closer, services to be closer to the people, then it becomes impossible because, if I need a radiology, if it's not available, I have to go where it is. So people move away from where they are. So the Afya Bora Mashinani principle, which is a promise of His Excellency, is actually to bring services closer to the people. And to do that, then we also need to see how do we sustainably fund the healthcare system.
My question is this, though. In a time gone by, what you are saying was absolutely true, because the healthcare facilities that people knew of were government healthcare facilities. But more and more we see the proliferation of private health facilities, and they are not necessarily that far away. Some of them are just around the corner. Would you say that they meet the needs that the government facilities were supposed to meet? Or do they also fall short? Because I understood what you said, how it is, you're essentially referring to the care-seeking behavior of people, where one will want care, but they know very well that this facility will not be able to care, so you move. But I'm saying, in the recent past, recent being some 20 years now, up to now, we've seen this proliferation of these health facilities. Do they help in any way to meet this need that would make people travel distances?
So if we look at the healthcare utilization patterns and where people seek service, you'll find about 40% of Kenyans still seek services from private facilities. That means those facilities have, somehow managed to close the gap. However, the spatial distribution of these facilities is what is, wanting, because they are largely, centered on urban centers, and you find that the government facilities had better penetration in what we call the hard-to-reach areas or populations that are largely rural, and then that is where you get the biggest challenge. So yes, they have assisted in closing the gap, but what we are saying is that what we need, from where I look at it from, is actually not services that are must be offered from public facility, but services in Kenya are offered from private, public, and FBO. And all of them are facilities of the healthcare system in Kenya.
So you look at it holistically.
Correct.
From all the three sources.
Fantastic.
What lessons have we learned so far in our, you said, we've had 2 trials at universal health coverage. What is it that we've seen as the positives, and what are the weak links?
Thank you. I think one of the things that we must first recognize actually is the fact that without a good investment in prevention of diseases, and then the healthcare costs continue to escalate. When I started working in the healthcare financing domain 15 years ago, the total health expenditure was barely 200 and something billion. We have doubled that amount to about 550 billion annual expenditure. But
what does that mean?
So that is the money we spend for health in the country from all sources.
Out of pocket?
Total. From everybody.
FBO, private, everything.
Government, government donors, corporations, household out of pocket, as you may call it, as well as government. So both national and county.
How much is it now?
It's about 550 billion.
Wow.
Annual. Now, the expenditure has been growing over time, but our indicators have also not really changed with the same, function, so to speak, if I may. So we realize that then there must be something that need to be changed in a way we channel our funding, and that is why we have to rethink the whole financing architecture as outlined within our Kenyan healthcare system. So when I highlight that, what I wanted to say is that as we move to the new agenda on how to finance health, one of the key lessons we need to learn is that numbers do not
lie.
There is a cost of care. And if the cost of care is at 10 shillings, if we provide 1 shilling, we should not actually expect that we'll provide 10 bob worth of care using 1 shilling. We must be very candid on that. The second thing that we need to understand is that if you look at the past policies, I've been saying that or showing that NHIF would be the vehicle to achieve universal health coverage. But when you look at NHIF itself, has no capacity or even ability to actually do that. And so then one must ask himself: are we promising, or have we been promising more than we can actually deliver? And that is why it merits to actually refocus on reform surrounding the social health insurance financing territory to make sure that we have an outfit that is fit for purpose.
But isn't this the reason why we amended the NHIF Act just last year or 2 years ago?
Yeah, but when you look
at... the whole focus by health economists such as yourself was look at NHIF and its capacity. Look at NHIF and the number of people that it's attracting as members, and those that are active members. So one of those conversations was, let's make NHIF compulsory, let's expand it, that's why we are amending the NHIF Act and saying that now everybody from the age of 18 becomes a member automatically. All those things. Now again we are amending the amendment of the NHIF.
Yeah, so the first thing is that we are not amending. Amendment. The amendment we have been amending is a law of the 1999, 1998. And that law, the way it was constituted, had some defaults, right? And that merited the revision of 2022.
What were these defaults?
One is that, the social insurance by design should actually be compulsory for everybody. And the contribution should largely be driven by what I would call ability to pay. The other important thing is that there should be a package of care that is provided, known, costed, and the value of that package is known. And is eligible and one qualify for it.
I'm sorry. Can you give an example of that? The reason why I asked that is so we can understand. When you say a package put together, I'm assuming that the end result then is also important, that you put in this contribution over a period of time. This is what you should get. Can you give an example of that so we can understand?
Yeah, we are just saying that just as you find in private insurances, for instance, when you become a member, you are given what are you eligible for?
Right.
How much are you around to spend, for instance? And you find that there are many times that people have gone to facilities, for instance, in the past, and the social insurance, NHIF had just paid for their bed.
Yes.
Right? And the question is that what they qualified for? So within a good social health insurance, you should have an amount such that even if you are going to a hospital that is, have a lot of ambience, that is not within the public, health level, public is majority. So you might go to where ambience is high. You must qualify and have some amount that is payable by a tariff.
Yeah.
All right. So that even the middle class who have been saying we pay this thing, we don't claim. All right. Now you will not have that chance because you are entitled to a certain amount of money, which you should be spending regardless of where you go to seek care.
Yeah.
Now, so that issue of tariff, package of care, and tariff make it better for everybody to access, and be eligible to the resources that they are accessing. We don't have those within the current NHIF. Needless to mention to you that the NHIF we have now is an old colonial outfit that ideally have focused for many years on the employed people. These employed people are 20% of Kenyans. So even if they were to be charged almost all their salary, it will be next to impossible for them to actually fund the healthcare of the 80 who are out there. And therefore, we must come up with a social insurance that is talking about the center of it is actually the 80. The 20 are, they are the minority, so to speak.
Yeah.
So for you to be, if one person is contributing in the social insurance currently, 20 goes into 80 4 times. So what we are saying is that for us to have good, healthcare insurance, the contribution of one household contributing in the former should shoulder another 4.
Yep.
That becomes difficult. And these are some of the realities that probably we have neglected over the years. And as CT highlighted, these numbers still are not lying.
Sure. I mean, you're in the art of economics and looking at it from a healthcare perspective. Is it actually possible, the way we talk about folks not being bankable to the numbers whereby we would want them to be able to operate as an economy? And here we are saying that the preferred or the desired route would be to have everybody compulsorily contributing. Is it possible to do that in Kenya today with all demographics considered?
Yes, it is.
Okay, how?
I want to first begin by going back to my total health expenditure.
550 billion shillings.
Out of that total health expenditure, about $1 billion, which is 140 billion also,
yes,
is actually money that comes from households. So people pay for that money.
Yes.
The only thing is that they pay for that money when they are in the hospital and sick. So they pay because they are forced to pay. It is difficult to do it. And then they strive to actually give those resources. And that is why they become catastrophic to them and impoverish them, including the urgency to actually form WhatsApp groups to actually mobilize for resources. What if we get into the business of being able to, contribute early before disease comes?
And a little
Unfortunately, health is not like any other commodity. You know if it's important when you get sick. So before you get sick, you feel I'm good, I cannot get sick, I'm young, I'm fine. But when you get sick is when you need to spend because you require to restore your stock of health. So then the people left on their own are unable to actually save for healthcare, that I'm keeping money to use when I get sick. And therefore, the social insurance is just providing an avenue where we compulsorily contribute, all of us, and do something called, pooling our lists, disease lists together. Globally, we only find that it's 5% of the population that require serious and huge health expenditures. 5%. So the 95
are contributing.
Are supposed to contribute. And as they contribute, we cross-subsidize each other.
Okay.
They are within normal health expenditures. And therefore, we can cross-subsidize each other as a country where the young subsidizes the old who get diseases more, where the rich subsidizes the poor. And this is the kind of mechanism that the spider web discussion brought about this morning. And I think that's where we want to gravitate the country to.
Daktari, I'm a bit lost somewhere. As I was saying, we saw the push to amend and successful amendment of the NHIF Act. So in the 2022 Act, it said that one, NHIF shall now become compulsory, that now we shall have more people contributing to the NHIF, that the government shall support those that are considered vulnerable, indigents. And we shall then see expansion of the cover or benefits that are offered by NHIF. Since then, the public has been going through public participation on regulations that are to operationalize the amended Act, which is where the talk of the 2.75% contribution comes in by everybody, a minimum of now reducing the minimum from 500 to 300, and then the benefits of it and how more people can start contributing to it. No sooner had we gotten into that engagement than now we are talking about repealing the NHIF Act, creating 3 new funds, and there's just complete confusion. We are talking about launching UHC finally, but we are repealing the law that was taking us towards launching UHC and creating 3 new different funds. I'm lost.
Thank you very much. So I think that one thing that I was trying to explain before we went to the break is the fact that we have had challenges with the current NHIF as it is, and more so its architecture. And that is
the 2022 one.
Yeah, I would not call it the 2022 one because the act I told you is 1998. So it's the amendment of the 2022. But why this is a key problem? One is that we need a social health insurance that is holistic. And that is what is being provided within the current setting. And the mistakes that we have done in the past must be corrected for us to move. And therefore, what we are saying then is that the new funds you are seeing, one is that they are not 3 new, NHIFs kind of things. So this is one social health authority. And this social health authority is looking at the whole landscape of healthcare financing. And what are we saying? In the past, we have seen that NHIF has only been covering largely higher level facilities, and therefore the incentivization is for you to go to higher level facilities. But we should have a social insurance or social, authority that is ideally taking care of lower level facilities, so that the people are able to go and seek services there
at the primary level,
at the primary dispensary and health centers. They should be equipped. They should have the right staff. They should have the right diagnostic capacity. And therefore, the people will go and seek services there. 2 things are important in this agenda. One is that it is 20 to 25% cheaper to provide services in lower level facilities. So that is how we cut our total health expenditure that has been increasing. The second thing is that those facilities are closer to the people. When, for instance, my mother is making decisions, do I want to go, to seek care today? She's thinking about her child probably who would come from school, her cows that need to be watered, some people in the shaba who need to be, given a meal or something. And unless it is very critical, she feels very critically ill, she will not go, and more so because it's far. But when the services are closer, she can do her things, and later in the evening, just go to the facility and get services. So then we are bringing an issue of early detection of diseases when the services are closer to the people. And this is what have been missing for the longest. And for those who remember, when we were growing up, if I look at people here, there used to be, people who used to visit households to check whether you have a toilet, whether the toilet is being used, whether you have a place to wash utensils and dry them under the sun for sterilization. This used to be there, whether your kids have taken vaccines, whether they have not. So we lost this. And when we lost this is because we started building a curative system. It's a market-driven kind of system. You get sick, you die medicine. You go to hospital, you pay a doctor. So these kind of things are the things that we are shying away from. And this will not be addressed by the current NHIF because it is, by design, it's one pool that ideally cater for purely, higher level facilities if you look at it. Now, so what is new? I think is a question that would be able to shed some light on what we are saying. We are saying that the new social health authority should be able to do one key thing: go to output-based financing. We are in input-based financing continuously at primary healthcare level. So this is where you send nurses to a facility, you send commodities to the facility. Some of them are stolen. Some nurses or human nurses, CEOs, doctors, some of them don't report to the facility. So they don't provide any care. But are you paying?
Yeah.
Yes, you are paying. So if you go to the other side and ask yourself, what if we pay for the service that they are providing and you purchase the service? That means that you start catalyzing the facilities to provide the service, even if they don't want it, for the sake of being paid back. Right? So that become a financing model that is different from the current financing model that is purely input-based financing. So if we go to output-based financing, then we need to get away of not only having a social insurance or social authority that is actually taking care of only higher level facilities, but also lower level facilities. And that merits the creation of what we are calling the primary healthcare fund. It is a fund just that is operating with the social health insurance authority, and what is happening, it is purchasing services from lower level facilities. In the earlier case, the push have been up to level 4.
Yeah.
But 3, if I go to a dispensary, nobody will pay for me. If I go to, or if they don't pay,
pocket.
You either pay out of pocket, but even if you don't pay out of pocket, the services will not be there because the money is provided. It's not provided. We must get a way of financing our facilities.
So how will it work then, the primary healthcare fund? Will it send drugs to the health center, to the dispensary? What will it do?
So the healthcare facilities are owned by the county.
Yes.
They are owned by the private. They are owned by the by FBOs, faith-based. So when you go to these facilities of this level, which are providing primary healthcare services, you will provide a card. They will give you a service. You provide a card. They will charge the card the same way NHIF charge for higher level facilities. They will charge that card for the services provided, and that money will go to that facility.
Okay.
So that facility have money to be able to improve its own services, because it can hire a casual nurse, or it can hire a casual CEO, or it can get cleaners to clean the house, the facility. It can hire a watchman.
It can buy bandages.
It can buy bandages. It can buy reagents. So what we are saying is that we need to start refinancing our facilities to be able to provide care at that level. And these facilities have their boards, even now, you know that. But these boards have little decisions they are making, all right? So money is largely, we have been funding care in a way that it incentivizes people to go to higher level facilities. That's where you find both the private and social insurance is paying.
Will there be a cap to how much money goes into the primary healthcare fund? Will there be a minimum and maximum?
There is
or
no
a
minimum.
percentage that says, out of the money that I contribute into NHIF, into this new authority, X amount goes to this primary health, which is outpatient. Then X will go into something else.
So the desire for the lower level facilities, which is primary, level 2 and 3, is that the public financed, the PHC fund is publicly financed. So there is no contribution there that is largely going from individuals.
Okay, so
right.
This is from the national budget to county budget, however, but it's coming from taxes.
Yes.
Okay.
Ideally, all right, as a social protection mechanism, to make sure that people access to care increases, and therefore, because you have a card as a citizen, you can make a decision to go to private, which is providing primary healthcare, public, or FBO. So, and because the FBO is retaining the money, and which it collects, the private sector first is also retaining the money, right? After providing the resource, the service, then the public should also, to clear the level, to make the level be very, same level, or level for the three types of ownerships. Then you find that also the government facilities, which are lower level, should have a mechanism of retaining the funds to improve themselves.
Okay. One of the problems has been, because we can look at the mechanics of all of this, the distribution pathways are flowing, everything is all right. Then when you have this, in place. But one of the problems, one of the issues that has been perennial, whether it's at the county down to the most basic level, has been this issue of adequate supplies, whether it's drugs, whether it's these things that we've been talking about, making sure that all of those things are actually stocked. Would there be, your lines of due diligence to make sure that these things are, because we can finance until, making sure that the money is available, but then it becomes now properly established, where you see that end to end, everything that is needed is actually done, so that this service that we're talking about actually does reach. Because finance can be great, it can be great on paper and the shillings have been spent, but then what about the guarantee mechanisms to ensure that healthcare is actually happening in the way in which it ought to happen?
Thank you. If I may just drift a bit and highlight that the key, this health agenda for this government is largely centered on 4 areas. The first one is on commodity security, and therefore we are talking about improving availability of commodities in facilities. And if these facilities receive the money through the reimbursements that they are getting, it is possible to order through a system. And that is why there is reform happening at KEMSA to make sure that they get an end-to-end feasibility in terms of digitization, so that the digital system that ideally send the commodities up from the market, from the national level, the counties can also be able to use the same system to dispense to a little person. And therefore, the issue of unique identification of an individual become very critical. So when you have an end-to-end feasibility of the commodity, this will actually address the issue of commodities not going there.
Can I add something here? So maybe it will give a little bit of highlight into the question a little bit more. Yesterday, we've given another example, and we've known this to be the case, that even if you have a card, right, you go to hospital, you've been treated, or rather, you've been seen by a doctor or a medical health professional, you are now supposed to be given medicine, and you are told that this medicine is not available at the facility at that point. However, sir, you may cross the street and you can buy from a pharmacy. We know those cartels are currently operating in the country today. So here we are saying that there will be end-to-end in all the medical facilities where you can go and present your UHC card, isn't it? What's to stop this current action then from happening? Because that's the bane of most people's existence. That I can have a card and it will treat me, but then what's to guarantee that I will get the medicine to complete the process? It's a big issue.
Yes, to address that issue is not very difficult because the solutions are there.
Okay.
One of the key thing is within the digital superhighway, or what we are calling the ecosystem. This is the interconnection of the whole healthcare system, so that even a small pharmacy has ability to order at the price that the big pharmacies are ordering at. The small facilities can be able to channel their orders through even the KEMSA system or any other meds or whoever big is purchasing, and they're able to get the commodities at the right price. Now, what is important is that the social health insurance card is not saying you must seek services from the government facility. So if the service is not available in the government facility, your card should be able to get the medicine from that
whichever faith-based
that pharmacy you are talking about. Should be part of the system. Now, when you leave these pharmacies out, then they have a huge motive to actually either steal government medicine, all right, or have commodities that the public does not have. And therefore, what we are saying is, give power to seek care to the person. If they come, they get a prescription, let it be done on a digital system. That prescription is available within the ecosystem. You can pick the medicine from a pharmacy inside the facility. You can also go outside and go to a pharmacy outside the facility
and buy from there.
Excuse
me, teacher, I have a big problem. I have a big problem with taxpayer money going to finance the development of the private sector. I have a big issue, because this is how the public sector will not grow. There's no incentive at all for the public sector, for a governor to put up a new health facility if a private sector can come and put up a health facility and it's receiving financing.
So
all the money that we are contributing, so it goes into the health budget, all the money from the health budget spreads to private. All the money that I contribute into NHIF still continues to go spreading into private. When shall we see the development of public health facilities? Or are we saying that we can, as long as we have health, that's what matters? It doesn't matter whether it's coming from public or private.
So I want to first highlight that providers, public, private, and FBO serve Kenyans. We begin from there.
Yes, they do.
The second thing is that providers of care, as you may call them, the key thing that we need to look at is, are services available? All right, that's the first thing. Are we incentivizing the public to actually have that service? Now, what you are saying will actually not happen. And I can give you a case example of Nakuru. When you look at Nakuru earlier, the NHIF money that was going to the public facilities was very low. The governor, they have come in, and what they have tried to do is to improve the services in the their facilities.
In the public health facilities.
Correct. What is happening now, Nakuru is one of the counties where the biggest chunk of the money goes to the
public.
So we cannot also not say that if the governor is not improving the facilities, their own facility, that Kenyans will not go and seek care. I mean, that is also not fair. So what we are saying is, we need to have the ground leveled. And that is why there is another bill. You see, that other bill called FIF.
The Facility Improvement Financing
Very good.
Bill.
Is to actually address what you have talked about. Because it is saying, when you receive the money as a facility, you need that money retained in that facility to improve care, to reorder, all right? To provide the inputs necessary to give the services. Because if you pass the bill as it is, the Social Health Authority bill, without the FIF, what you are explaining will happen. But when you have the FIF bill, which is saying that just as the way the public, the private is, and FBO has received the resources, you have double, because you have the shareable resources that comes from the county. All right? You have been added some more money for cash up to make sure that as a facility, you have funds to provide the care. So what you are saying will ideally not happen unless we that is why the two bills are important. Actually, all these bills are related.
In this
so
country, this country, we know that we've seen the faith-based organizations have been building health facilities for many years. And why were they doing that? They were doing that because the government was not doing so in those communities, primarily. When it comes to faith, when it comes to healthcare, when it came to education. That's what the churches and the mosques and the Hindu communities were doing, building schools, because the public sector was not doing so. And then we saw private sector coming in, especially in education. And private sector was also bridging a gap. Government had sat back. It wasn't building schools. It wasn't developing our facilities. Private sector had to come and catch the gap. Same thing with our healthcare. Now we are saying that we put equitable amount of money. This public sector that has not been thinking of actually developing itself will have some money. And then some more money will go into private. Another money will go into faith-based. And let them all develop. We can all see where the catch-up will be.
Not only that,
I fear that the government will sit back and not build hospitals, because anyway, see, there are hospitals in Kenya.
but even more importantly, the reason why the private sector, whether it's in education or health, flourishes is because people lost faith in government facilities a long time ago.
Yes.
So how do you regain this faith? I actually like what you're presenting. It actually makes sense. And it's ideally what should work. But then we don't live in an ideal world. How do we get people to understand that what you're saying will be of benefit to them? Not that it works, because it can work, but it will be of benefit, because the trust and faith in what works was long shifted to the private sector.
Thank you very much. So I think we must accept that a time comes when a change must happen. And, even if the river had lost its course, it must return to where it's supposed to be.
This river is flowing upstream.
So even if it's flowing upstream, we have to make sure that majority of Kenyans who are still not accessing services, and also that when it's purely driven by the private sector, also there is an erratic increase in the prices,
Yes.
of healthcare.
Yes.
That is a market demand,
The
of course.
550 billion shillings explained.
Correct. So what we are saying then is that we must look at this reform agenda holistic. What are we saying? That we need an FIF bill to make hospitals have an autonomy, just as schools have autonomy. They sit down, they make decisions on some resources that they have. All right. But we have been pushing our healthcare workers to provide what they cannot do, because the environment is bad. They are not resourced efficiently, and therefore this cannot happen. So what we are saying, let facility have some form of autonomy, let them get financing, and when they do it, we will be able to see traction. That is the FIF. I wanted to just highlight that because it's important. The second thing is, after you get the primary healthcare, which if you look at countries like Sweden, Norway, for you to go to higher level facilities, you need to be referred. You cannot just wake up one day and feel the way I am feeling.
Go to their Kenyatta.
I am going to Kenyatta.
Yeah.
Surely, when you go to Kenyatta, you find that Kenyatta has one of our best trained human resource. And when you go there, for something that you did not require them, that is misuse of resources, because they are very expensive every time you actually engage them. So we are saying the base is first go to a primary facility owned by public, private, of FBO, and then you are referred. When you are referred, you go now to the social health insurance cover. It's a referral system.
Okay.
You go to the social health insurance. Now, it doesn't mean that because you started in the primary, nobody paid for your care. The person who provided was paid for.
Yeah.
And therefore, they should be happy. And I just want to quickly highlight these three funds so that people stop getting a little bit confused on them as you highlighted. So when you are referred to the upper level, from level 4, this is the sub-county hospitals.
Yes.
And then we have county hospitals, the level 5. The former provincial hospitals, those are level 5s. You have now your card, which is a social insurance card.
Yes.
And that is a card that is contributory. That is the one we have been paying for. That's the one that we are putting our risks. All right? And that card is very close to what we have with NHIF, but different. Because the target is 80% of Kenyans.
Daktari, please allow me to pause you kidogo. We go to the news. We were to have a guest who was to join us this morning from the African Union Commission. Unfortunately, she'll not be able to join us, so we have some time. And so many people want to ask you questions. Would it be okay if we take some calls? For a couple of minutes in the next hour. We'll continue.
Then we take calls.
We will continue.
No, we will give you the time to finish exactly what you want to say.
In the next hour.
All right.
So you stay on. So Dr. Daniel Mwai, who is the President's advisor on health financing, stays on for the next hour.
This is the Situation Room, the only way to start your day.